Good morning, everyone. I think good afternoon in Ukraine. First of all, we'd like to thank our friends, our great friend Alexander Wozniak, for the very kind invitation. I'm talking from my city here in south of Brazil, the city called Curitiba. Curitiba in the state of Paraná. Paraná, the state at more than 600,000 descendants of Ukrainians. In this state, you have cities like called Prudentopolis, that 8% of the population is descendant from Ukraine. My former chairman, Afonso Antoniucci, is descendant from Ukraine. Well, this is a great honor to me, to my university, to my city, and my state to talk to you. Today we'll talk about vestibular schwannoma, a common tumor. But looks like today there is no more problem. Years ago, the surgical technique, the microsurgical removal, was the main point. After came radiosurgery, after we start to understand more the pathology. Now, I think we have to think and talk about vestibular schwannoma from a reality way in the whole world. You cannot put in the same pocket, in the same basket, schwannomas like this, a small one in the intrametal, in the fundus of the meatus, with this very large tumor, brainstem compression, and probably severe hydrocephalus, intracranial hypertension. There are completely different ways to see this tumor and different ways to treat. When you talk about vestibular schwannoma, you have to understand how will be our goal related to the tumor, related to the size, related to the location, and the clinical symptoms. Also, the symptoms and the clinical condition of the patient. There is no one treatment. There is no treatment. You have to choose and tailor to each situation. Before talk about any disease, any kind of neurological, neurosurgical disease, we need to understand the natural history of the tumor. In the natural history is this. This is a very nice paper of Walsh that showed that 72 patients treated in follow-up 37.8 months, 83%, the growth was less than 2 millimeters per year. In 36%, more than 1 less than 2. 50% of the tumors doesn't grow or just 1 millimeter per year. Millimeter per year. And 13.6 decrease in size is the natural history of vestibular schwannoma. You should learn also that the hearing that the people is talking about today a lot, to preserve the hearing, is related with the behavior of the tumor. The tumor that grows fast or more fast than the other one, it can lose the hearing fast. The other one that's growing slowly, they can preserve the hearing, and the impairment of the hearing is very slow. We also should know that there are another kind of treatments: microsurgery, radiosurgery, and no surgery. The conservative treatment is still an option. It should be an option in some situation. Look at this. The natural history in this paper by Shirato show that the growth per year is 3.8 millimeters and radiosurgery 0.75. It means that the radiosurgery works. Radiation therapy works. It's an option. However, does not mean that is the option to everybody. We have a case like this, you have to understand it's very slow tumor, but look at this. 2006, very, very small tumor in the fundus of the meatus. And somebody say to this lady, oh, go home, no worry. Very small tumor, never had problem. 2011 was like this, a very large tumor that you couldn't talk about hearing preservation. You tried to facial preservation, but the most important save the life of this young lady, despite a very slow growth of this tumor. Some situations they can grow very fast and benign, histologically benign. Today, the word in vestibular schwannoma is radiosurgery. Radiosurgery is radiosurgery for every case. This is the first choice in many countries, in many centers. But we should tailor the situation. First, with the size, to understand the size of the tumor. We know that the radiosurgery decrease. We know that the preservation of the function in the first month, or maybe first 1 or 2 years, will be very high. But it's not curative. Look at this. Gamma knife treatment, 6 months, 9 years. Oh, good. But the tumor is still there. This tumor is dead. Are you sure that's dead? The tumor is there. You keep on doing MRI. I don't know what's happening if you come back or not. The people from radiosurgery that you never come back, but the lion is still there. They can grow again. You don't know what's happened. The only curative treatment is the microsurgical removal. Now there is this new idea that's coming, you call adaptive hybrid surgery. What's it? You do a planning, preoperative planning. You design and understand where is the facial nerve, do the partial removal, and leave one small piece for radiosurgery or to follow. Radiosurgery, they can say. What the situation happened? Man, I beat you. See if somebody here can find the facial nerve in this tumor here, in the MRI. Show me in the MRI where is the facial nerve. Many, many times in surgery, it's difficult to find the facial nerve. Imagine in the MRI for this great tumor. And leave a small piece, look at this. This yellow here, the facial nerve will be here. Not 100%. Still, the microsurgery training and the microsurgical techniques are very important. And in surgery, you see the real facial nerve location. For me, hybrid surgery is this. You do the surgery, you remove the maximum that you can, and there is a small piece that it couldn't remove, that it was very attached to the facial nerve, you leave it. And maybe you give radiosurgery, maybe you wait, but this is the real hybrid treatment for acoustic neuroma. Remember, radiation is for malignant tumor. It's not for benign tumor. If you send to radiation, maybe in the future, you have malignant tumors in this crazy tumor you call radiation-induced meningioma. benign meningioma, but with terrible behavior. Everyone that listening here had a case of a young child with medulloblastoma or ependymoma that did radiation in the past and now coming with this radiation-induced meningioma. The world is so crazy today that you see publication like this. Look at this, my friend. Efficacy of stereotactic radiosurgery for radiation-induced meningioma. Okay, maybe you need to give radiation. Maybe you give complementary. But look at the example here, my dear friends. Man, this meningioma can remove the tumor and with 5 centimeters margin. Cannot be the example. Treat fire with gasoline. The history of treatment of acoustic neuroma changed a lot of microsurgical understanding of the tumors, with understanding of the anatomy, understanding of the behavior, and one very important point, the intraoperative monitoring. It's very important. It's changed a lot and increase our results, and the morbidity go very low now with this kind of management. It's very important to have a nice machine with no delay that you can follow and do the way. Surgical position, everybody likes one. Huh? Some people like sitting position, some people use lateral position, some people use three-quarter prone, some people use ventral, I don't know. Do what you feel more comfortable. You and your anesthesiologist. It's very important. The team has to be comfortable in the OR. If it's good for you to do sitting position, but for the anesthesiologist, it's not good. He's not comfortable. It's not a good idea. The teamwork, everybody has to be comfortable and secure. We do straight incision, little bit curve, so anterior here, but especially straight, center in the external auditory meatus. Do the posterior fossa craniectomy or craniotomy. I prefer to do craniotomy and put the flap back, because if you do craniectomy and the muscle go over the dura, the patient have a lot of pain in the post-op. I use the craniotone here in the middle, and the part to the mastoid, I use the drill to expose just the posterior part of the sigmoid sinus. I like retrosig. I know that the people, when they do surgery with the ENT, they like the translab. I prefer to do retrosigmoid approach. You go down, they expose the posterior part of the border, the transverse sinus, the joint of sigmoid sinus and transverse sinus, and do the craniotomy after put back. But this here is the most important thing, to understand the 3D vision, where is the structure? And understand that the most important trick to remove acoustic neuroma is to find the layers, the arachnoid layers and the membrane layers over the nerves. Like an onion, you know? You go peeling the layers, the arachnoid layer, and the tumor will come out for you. Tumor like this, a small tumor, you open the internal auditory meatus, you expose the tumor in the auditory meatus, you expose the tumor in the posterior fossa, and you work lateral and preserve the nerves anteriorly. This same technique for a small tumor you need to use for large tumors. This example is a small tumor intrameatal. The patient has hearing, has facial nerve. This case, the case you can try to preserve the hearing. A small tumor with hearing, patient with hearing, go there and try to save. but it's not 100%, maybe 50-50, maybe 60, but tell the patient the truth. If you do radiosurgery for this case, you save the hearing immediately, but in the follow-up, the patient will lose the hearing. And the patient will receive radiation in the posterior fossa. And the patient may have trigeminal pain and hypoesthesia. If you can do microsurgical removal of the vestibular schwannoma with radical total removal, is curative and don't need radiation, don't need to see in the past. See, work in this direction of the nerves, go slowly, piece by piece, cell by cell. You can go there and clean the nerve, avoid a lot, avoid coagulation. See, you never know how hard it will be. See, and do it. This you can do everywhere. Just understanding the anatomy, understanding the tumor, and understanding the physiology of the tumor by itself. See, you can do the radical removal and do this a small piece. Okay, you can do this in small, you can do a larger one. Another case, big one, same situation, is you do the same technique. Now you go first, take CSF leak, release the CSF leak, no, release the CSF, not CSF leak, release the CSF, this layer that I talk about, see? Open, around. You can do the decompression first or go directly to the internal auditory meatus. It's your choice. You go faster here. Now you go to find the plane. You do the internal decompression. See? Coagulate just a little bit the way you can remove. Internal decompression is for large tumors. This is the trick. A lot, debulking. The tumor will be smaller. And now find the lower cranial nerves and found this layer here. Look at this. When you found this layer in front of the tumor, game over. You know where is the facial, you know where is the structure, you just follow it laterally. I go faster here to the end to understand. You see here, there is the layer of the nerves. There is some little bit blood. Do not coagulate, just irrigate, just irrigate. In sitting position will be very nice because it will be very clean. But you use lateral position like me, just irrigate and keep the facial and the acoustic and the cochlear nerve in the anatomical position. You can preserve the cochlear nerve anatomically, but does not mean you preserve physiologically. See, in the end, the vein, the petrous vein, the 6th nerve, the 7 and 8, the 5, and the whole anatomy in front of you. And the post-op, you have the preservation of the function, the facial nerve. See, put some glue in the middle ear, sorry, the internal auditory meatus, not middle ear, internal auditory meatus. Okay, and just release. Another situation, very similar tumor, you do the same, almost same thing. Open the internal auditory meatus, liberate the nerves, identify the facial nerve, identify the structure. Then you see, I like to use the cutting burrs. I feel safer. The people say, oh, I use diamond. Sometimes diamond have to push too hard. With cutting, you go just touching like a painting, you see. Use the drill the same way to use the pen or the pencil, like a knife. Go slowly, see. The same situation like this. In the end, you see the structure here, and you remove the tumor, preservation of the facial part. The trick to be calm, found the arachnoid planes, find the structure. Now I'm using the endoscope, not doing more this blind dissection. I use the endoscope to see the fundus of the internal auditory meatus. Same situation again. Big tumor is post-op, immediate post-op, first day post-op. Look at this. The patient preserved the smile. Is this most important thing? Another situation like this looks like confused. I couldn't see. I couldn't identify the nerve. I just identified the layers. See? And keep the arachnoid to the nerves. Was like the onion was there. This layer here, I didn't see the nerve. Where's the facial nerve? I had no idea. But it's the post-op preservation of the function, because you preserve this layer of arachnoid. This is the trick. More case, same situation, same approach, same thing. Large tumor, same layer. Cystic or some necrotic, a little bit more difficult. But independent of the size, you can use the same anatomy. This is the case. Cystic acoustic is the most difficult one, because the facial nerve sometimes you have no idea where is it. It's between the arachnoid there, but go and leave it. Sometimes you think, oh, I leave some piece of tumor there, but was just the arachnoid. But if there is a small piece that is attached to the facial nerve, you can leave. You can leave and follow it. Or if this small remaining tumor start to grow again, you can give radiosurgery. Here's the result of surgery and radiosurgery for hearing. It's impossible to understand this. It's similar, but in the microsurgery, the preservation of hearing is forever. In radiosurgery, there is a limit time. I'm not saying this, just not me. The literature is saying this problem. Look at this, very small. The voice here is complete preservation. And you go there and take like a small ball, a small tumor in the end, remove the tumor, and preserve the hearing in this small tumor. This is very important to understand this anatomy. Open widely the internal auditory meatus, preserve the arteries, the vein, and the blood supply to the nerves. In some situation, the patient lost the hearing, or in NF2 is completely deaf. You need to do something. This is situation that you can use in the same operative field. The implant of cochlear implants. This is the case that we published. We did very small tumor in the fundus. We did a translab with our friend ENT, Dr. Rogério. You remove a small piece of tumor, it was in the fundus, and implant in the same time the cochlear implant. This is a very nice idea. The patient is improving, can hearing, but they need a lot of physical therapy, and the people and the patient has to understand and collaborate a lot. Here, before do this surgery, the cochlear implant for acoustic neuroma, talk of the patient, explain that in the post-op, the restoration of the hearing will need a lot of his help and support. See, to the therapy. See, need to adapt itself, because the sound will be different from the normal, from the one that has the implant. It has to adapt itself. This will have some time. But if he understands it, it will be Great. It's a very nice idea. There is another situation that the patient is completely deaf. It's like the patient with neurofibromatosis. That one small noise, would be great to him, can save his life. Can hear the bus, the car on the street, can save his life. I know that the auditory brainstem implant, technically, is a little bit more difficult, but it's more difficult the recovery. The patient to adapt itself, has to work a lot. The patient has to help a lot. But some hearing for this guy that is completely deaf may save his life. This is the future of treatment with the patient with hearing loss secondary to vestibular schwannoma, with neurofibromatosis or not. This is the technique. You did some case like this, identify the fourth ventricle, identify the lucica, you put the electrode, you stimulate, you know where is the position. It's very important to turn on the electrode in the intensive care unit, because you can have a severe arrhythmia, cardiac arrhythmia. See, it's very important to do this when you implant. In surgery, you stimulate just to know that it's in real position. Okay, if it's okay, you close, wait another day, you wait maybe 1 week or 2 weeks sometimes to the patient adapt itself and turn on the device. Not always is happy. This is the patient with large tumor. This surgery is to save her life. We tried to save her life, but you couldn't save her facial nerve function. Very interesting. This lady who went to the church and she decided the facial palsy that she had was the desire of God. And she said, I will never more do the recovery because it's part of my mission here in the earth. Crazy, no? In the post-op, you remove totally the tumor, you save her life, but the facial nerve is there. Today, there is a lot of things that you can do to recover. The hypoglossal terminolateral or for static is okay, look at this. But when the patient moves, you show the palsy. But there is now new techniques for facial restoration or facial reanimation that is helping a lot. In my country, I think in your country, you have a lot of cases or a lot of patients with large tumor. That our first mission is to save the life. The second mission, save the facial nerve. And maybe save the hearing. This is a new technique that our friend Dr. Maggiani is doing. You see, very nice, that mesenteric transverse nerves. It's very good results. Now the plastic surgeon, the neurosurgeons, they are doing very nice job in facial reanimation, and is helping a lot these people. I'd like to thank you all you for the opportunity. I invite you to come. Was into 20, now March 20. Now will be March 22. I hope the COVID and the pandemic gone, and I hope many Ukrainians can come to Brazil, can come to Rio de Janeiro, one of the most beautiful cities in the world. And maybe could travel to Paraná to know and to be proud of the work of the immigration of Ukraine make in this country in Brazil. Thank you very much. I really appreciate the opportunity to be here today. Thank you.